family stuff. So if the afternoon class is short, our class is short. So I pulled some stuff out of the lecture that you'll be fine with as far as the final goes, and we'll do it next spring. So just to let you know, we'll probably get out pretty early today. So our last little bit as far as signs of ischemia, we've talked about ST elevation, we've talked about T wave changes. We're now going to sort of circle back and talk about ST depression. Just like the T wave changes, some of this is going to be repetition. For example, we're going to mention reciprocal changes, which I think everybody has a good handle on. But again, the reason for this was when we went through this before, it was from the viewpoint of there's a STEMI, how do these things relate to a STEMI? And now we're going to say, well, even if there's not a STEMI, do we need to look out for T wave changes in ST depression? So that just involves some repetition. I don't think that's necessarily a bad thing. So, we know what ST depression is, but what we haven't talked about is the shape of ST depression. And generally speaking, and I say that like that because there's always exceptions to this kind of observation, is that flat or down-sloping ST depression is worse than upsloping ST depression. And let's look at some pictures so we know what we're talking about here. So this is much more likely to be indicative of ischemia, and this particular pattern, which we'll look at in spring, is much more likely to be because of something like left ventricular hypertrophy. You don't need to know that specifically now, but it's a benign, the depression itself is benign under those circumstances. So for example, here, and so Chris, why the ST depression in 1 in AVL, why is it there on this particular 12 lead?
Should be a posterior study, right?
So check again. Just kind of go, you've got lots of time, take a moment and kind of scan through the 12 lead itself and see what jumps out at you as not being all that great. So do you see ST elevation?
Yeah, 3 and 8.
Good, okay. And so with that in mind, why do you think that the ST depression in 1 in AVL is there? Maybe you said it and I just didn't hear it.
Now I'm confused that I'm getting something wrong.
Well, maybe I heard it wrong.
I said posterior semi.
Oh, you got it wrong.
Yeah, there we go.
Okay,
That's the
okay, somebody help him out. Yeah. Reciprocal changes, but not for posterior, for the inferior.
yeah.
Yeah.
Yeah,
It's just
makes sense.
early morning, and that's why we're going through this. So, but again, the point here is that it is definitely this, if you will, bad shape. It's very down-sloping, so the J point is here, and then it simply dives down. And again, here's we have the same thing here. The ST depression is going down, this time in reciprocal changes for the high lateral. So that's considered worse than if it's sloping up. Now, some causes of ST depression. So what causes ST depression? We already know the first two, reciprocal changes in a STEMI, and then posterior MI. Natalie, why do I say that's actually a kind of reciprocal change when we see ST depression and we think possible posterior?
Because you see depression in V1 and V2, I think it is.
Uh-huh.
There is a posterior STEMI plus indication. You just don't move your electrodes to see this.
Correct, and it's a reciprocal change for which?
The posterior leads.
Yeah, the posterior lead, so V7, 8, 9. So, but we're going to give it its own case, even though this is reciprocal changes. We're going to give it its own line, and then we actually are going to talk, even though it's repetition, a little bit more about reciprocal changes in posterior MI, And the really new topic we're going to go into today is non-ST elevation acute coronary syndrome, which includes NSTEMIs, which I've gotten questions about, so hopefully they'll be answered today. Other reasons for ST depression are bundle branch blocks and left ventricular hypertrophy, which we'll talk about in spring term. So first class back in spring term, we'll be going through bundle branch blocks. So this is what we're going to talk about today. And again, we'll go through the first two topics pretty quickly because we've already done it before and it's just kind of a review. But we're going to go into it in a little more depth. So as we're all aware of, reciprocal changes are a mirror image, although mirror image doesn't quite say it, it's a flipped over, it's an upside down mirror image of a STEMI. And I think, again, we're all aware of when we see reciprocal changes, say in 1 in AVL, which are related to the inferior STEMI, it doesn't say that there's a problem in 1 in AVL, it's a reflection of what's happening in the inferior leads. Oh, in fact, that's what it says on this slide. If you see ST elevation in the inferior leads, the ST depression confirms the inferior STEMI. And again, this is old news, but it's a little bit of a summary of what we already know of where the, if this is where the ST elevation is, this is where the reciprocal changes are going to be. Okay. So Grace, what do we have here? Where's the STEMI? Where's the reciprocal changes?
You have a STEMI in inferior leads, and you have 2, 3, and then you have depression in 1, 8,
Correct. So it's an inferior STEMI with reciprocal changes. So why are reciprocal changes so useful? We've already talked about reciprocal changes already, so we're going to delve into this a little bit more today, but we should already have a sense of it. Koa, in what way have you found reciprocal changes useful?
For me, it's just to help confirm a STEMI.
Okay, confirms the STEMI, okay. Anything else? I mean, that's the big thing, but we're going to say exactly what that means. So, reciprocal changes confirm the presence of a STEMI. In spring term, we're going to jump on the STEMI mimics, and by STEMI mimics, I'm talking about things like pericarditis that cause ST elevation, but are not STEMIs. And so none of these mimics have reciprocal changes. So pericarditis, bundle branch blocks, early repole, none of those have reciprocal changes. So reciprocal changes are great because they really do confirm it. And at this point in your learning, you might think, well, why do I have to confirm it if there's ST elevation in 2 or more contiguous leads? Isn't that good enough? And again, the answer is that there are things that mimic STEMI. So reciprocal changes really are great. So that's one thing. But the other reason why reciprocal changes are really great if they're there is that sometimes the reciprocal changes are easy. They come first. They're easier to spot than the ST elevation. So, for example, here, there is just a tad of ST elevation in 1 in AVL, but it's not dramatic. You'd have a better chance of seeing it if you had a straight edge and were actually doing it. But believe me, it's not more than about 1 millimeter. And that can be hard to see, especially if the isoelectric line, here it's pretty flat, but when you have one of those wavy isoelectric lines, it can be really hard to spot. On the other hand, the ST depression in 2 and especially 3 in AVF is easy to spot. So when you have, what you should start to be doing, and you probably already are, is to start thinking in patterns. So what is an inferior STEMI is, ST elevation in the inferior leads with possible, if you have a high lateral STEMI, what goes with it is ST depression. And in a case like this, if you're just looking at it, you might miss that ST elevation, but the the ST depression in 2-3 AVF forces you to really consider, is there a high lateral? It's more obvious. So that's another really good thing. I have a close-up of it here. You can see that. Again, with a straight edge, you're going to be able to see the ST elevation, but it doesn't jump out at you. Here's another one. So, Kyle, where's the STEMI here? Where's the reciprocal changes?
STEMI and the inferior leads 2 and 3, and reciprocal changes in 2-3 AVF, and reciprocal change in AVL.
Uh-huh.
Really looks like it.
Yeah, and remember that we only need one lead of reciprocal changes for it to count. By the way, I think we could argue there's a tiny bit of, because the J point, there's actually it's probably up a little bit, but that's a moot point, so we can definitely see it in 3 and AVF. By the way, in terms of this particular STEMI, what else makes you think, oh yeah, there's problems in the inferior leads? Beside the ST elevation and the reciprocal changes, what else doesn't look great in the inferior leads? What about the T wave?
It's not swooping.
It's not swooping. Yeah, right. So there's here, this one's flattened out. This one's not too bad, but this one is really straightened out. So again, that's just a little more evidence there. Sometimes the reciprocal changes don't just confirm the STEMI, but they predict the STEMI because they can precede the ST elevation. This is particularly true with AVL. Okay, that is a special case. And many times, a tiny bit of ST depression and an inverted T wave in AVL are the earliest signs of an inferior STEMI. So we're going to watch another Amal Mattu video that has examples of this specific phenomenon. Okay.
Greetings, everyone, and welcome to the ECG Case of the Week for the week of March 27, 2017. This is Amal Mattu at the University of Maryland School of Medicine in Baltimore, Maryland.
Oh.
And this week, we're going to do a little bit of traveling.
If you
beyond
look
Baltimore.
on your
Some people
handout, I
mentioned,
believe I have
they've been missing our
the
traveling
12 leads.
song,
Should be right at the
Jones'
beginning, I
theme
think.
song. And so we're going to return to that today. We're going to start out here in Baltimore, and we're going to do our first case of 4 down in Florida. After Florida, we're going to fly all the way to southern India in Bangalore, and then we're going to get back on our airplane and fly all the way out to Vancouver Island in Canada for the third case, and then we are going to return down to
So you
Florida
just have to
for our
look at what he
fourth
has.
case, and we'll finish
Yeah.
up there. So we're going to put Indiana Jones off to the side, and we're going to do a little bit of traveling this week. We're going to start out, as I mentioned.
You're right under the speaker, aren't you? Is that good? Everybody can hear? Okay.
To work in Brevard County, Florida. Robert has been sending me cases since he was a senior resident, actually. And some of these cases have been really, really helpful. All of these cases have been really helpful. And so my thanks again to Robert for being a dedicated listener and contributor to the ECG videocast. This is an interesting case. He had a 66-year-old man who came in complaining of 1 hour of retrosternal chest pain with nausea. Clearly, these are concerning symptoms. We're going to get a quick 12-lead ECG and hit your pause button and take a look at this and see what you think about this. By the way, the ECG machine is at most just going to call this non-specific. And the reason the ECG machine is going to call this non-specific is because out here in the anterior leads, there is maybe just a hair, just a tiny, tiny bit of ST segment depression in some of these anterior leads, probably less than 0.5 millimeters. So your ECG machine is definitely not going to call that positive. We've talked about this before. The ECG machine will not call something positive unless it's at least a full millimeter. But the other reason it's going to call it non-specific is because of that ST segment down sloping in lead AVL, and maybe just a little bit of ST segment sagging in lead 1 one. Hopefully many of you have picked up on this. We alluded briefly to this last week. We've talked about it many, many times before. This is your key feature, that ST segment downsloping or ST segment depression or flip T wave in AVL is predictive of an impending inferior wall STEMI, and Robert was all over this case right from the start. Patient had persistent symptoms, and so what did he do? He got a repeat 12-lead ECG. I love it. And here is what you end up getting. There is now ST segment elevation in the inferior leads. This patient's having an inferior wall STEMI. 1 and AVL are looking worse. And maybe there's a little bit of ST segment depression in lead V1, V2, V3 with those upright T waves in those same leads. This might very well be a posterior STEMI also, so at the very least, inferior STEMI, possibly with posterior extension. And sure enough, this patient ruled in, went to the cath lab and had a 100% left circumflex occlusion. Sorry about the misspelling there. So it's a very simple key point that I want to hammer home with 4 cases this week. And that simple key point is something we've talked about before. We're going to keep talking about it because it is so important and still being missed. ST segment depression or downsloping and or flip T wave.
That's T-wave inversion.
AVL, the setting of some concerning symptoms, often predicts an inferior wall STEMI. So here's the thing. If you're in the cath lab, and believe it or not, interventional cardiologist once told this to me. I don't know if he was serious that he actually did this, but here's what he told me. He said, if you are in the cath lab and just for fun, you tie off somebody's right coronary artery. Again, I don't know if he actually did this, but anyway, that's what he told me. Just for fun, you tie off somebody's right coronary artery, the first thing you'll see is not ST elevation in the inferior leads. The first thing you see is the T wave in AVL gets flipped, or at the very least there's ST segment sagging. So the ST segment starts sagging down, maybe a flip T wave. That's what you see in lead AVL. And then later, then you start developing the ST elevation in 2, 3, and AVL. So this reciprocal change oftentimes precedes the ST elevation. This is a key point that Henry Marriott, one of the true masters of electrocardiography in the history of ECGs, talked about 30 or 40 years ago. It's still not well disseminated. We got to disseminate this information. When there's concern, even if that initial ECG is non-diagnostic because the ST elevation hasn't occurred yet, the patient's got concerning symptoms, get repeat ECGs, and especially when you see AVL showing this reciprocal change, get a repeat 12 lead because you may be surprised in the next half an hour, 45 minutes, 1 hour, you may then diagnose the full-blown inferior wall STEMI. All right, let's do a few more cases. We're going to go out to Bangalore, India, where Dr. Satish Bharti, who is a third-year emergency medicine resident, sent this case in to demonstrate this once again. And this is another case of helium. 72-year-old man comes in with bilateral arm pain and diaphoresis. That's a bad word. Diaphoresis always ought to make you worry. I always tell our residents, if the patient sweats, it ought to make you sweat. Diaphoresis is bad. Anyways, no surprise here. A 72-year-old with bilateral arm pain, you're going to get a 12-lead ECG, even in the absence of chest pain. Well, here's a 12-lead ECG, and Satish was worried about lead AVL. It's subtle, isn't it? The ECG machine missed this, but there's downsloping of the ST segment and the flip T wave out there. He was worried about the presence of an impending inferior wall STEMI. Now, there is just a little hint of ST segment elevation in a couple of these inferior leads. Many computers, this computer, in fact, may have, but I know many other computers may look at this and call this early repolarization. This is not early repolarization. You should never diagnose early repolarization when there's a flip T wave or ST segment depression in AVL. That rules out benign early repolarization. You cannot have benign early repolarization when AVL is abnormal like that. There's just a little hint of ST elevation in those leads, not a full millimeter, so your computer won't call it yet. But what Satish did, he just got a repeat 12-lead ECG 30 minutes later, and you remove all doubt. AVL is looking worse, but the key thing now is that there's new ST segment elevation. And the first thing you saw was just the ST segment changes and the T-wave changes, the reciprocal changes that lead AVL. All right, how about another case of impending inferior wall STEMI? This is from Vancouver Island in British Columbia, Canada. This was sent by Dr. Hugo Van Royen. You had a 73-year-old man coming in with an episode of lightheadedness and some mild chest pain while walking to church. The patient was a bit bradycardic, typical for inferior wall ischemia, by the way. Here's the initial 12-lead ECG. Again, this is another example where the computer's just going to call it non-specific. The computer doesn't know that this ST segment sagging in AVL, sagging, is typical of inferior wall ischemia, early inferior wall STEMI. The other clue here, by the way, is that, as we talked about last week, take a look at how straight the initial part of that T-wave is. That is not normal. And there's also kind of a Wellens type of appearance, or biphasic T-wave appearance in lead 3. Now, that's not called Wellens, because Wellens talked about biphasic T-waves in the mid-precordial leads. This is not called Wellens technically, but there's no reason to think that biphasic T-waves in the inferior leads are useless. They should also make you worry. But really, what tipped us off is that there's very, very straight initial portion of the T-wave there. That's a sign of early cardiac ischemia, and then we've got that AVL finding once again. So what ended up happening with this patient? Well, 10 minutes later, patient then starts to rise those ST segments. Just a little bit of elevation up there, but it's enough for the computer to call it AVL is looking worse. And also, another point that we mentioned last week, take a look at the height of those T-waves. The T-wave is larger than the QRS complex. That's not normal. That's a sign of early ischemia as well. So they activate the cath lab, patient goes up and is found to have a 100% RCA occlusion. How about one more case? This is from a good friend, Dr. Todd Haber in Lakeland, Florida. Todd has sent us a large number of cases that we've been able to take advantage of and learn from. Todd was taking care of a 66-year-old man with 1 hour of chest pain. He gets a quick 12-lead ECG. Actually, I take that back. This was the EMS ECG, number 1, I will mention. This is the first one that the paramedics got. And there's not a whole lot going on. There's maybe some Q waves in V1, V2, V3, but those might be old. I'm not really sure what to make of that. AVL, we're all paying attention to AVL. It's just kind of flat. I'm not going to make too much of that. But what they did was they repeated the 12-lead band. Here's number 2, and you now see the patient has a new flipped T-wave in AVL. So there is a new finding, which the computer will not even notice. The computer doesn't pay much attention at all to AVL, but you do. You see this new flipped T-wave in AVL, and that makes you worry about an impending inferior wall STEMI. Patient arrives, Todd grabs the new ECG, and sure enough, now there is full-blown ST elevation in lead AVF, lead 3, lead 2. This is a full inferior wall STEMI, and the first thing that predicted it was nothing more than a new flipped T-wave in AVL. This patient went up to the cath lab and had a 99% RCA lesion that had to be opened. So 4 simple cases, Dan, are one key point. Gosh, I know you're going to see cases like this. It's just so common. People have sent me dozens of cases of AVL predicting inferior wall STEMI. It's that common. It's out there, and your computer will not pick this up. So pay attention to AVL. Most people just completely ignore AVR and AVL. Those 2 leads help us a lot. We'll talk about AVR in the coming weeks, but for this week, pay attention to AVL. It is the very, very first lead to show reciprocal findings in the presence of an inferior wall STEMI. And these reciprocal changes often precede the ST elevation. Again, a key point that Marriott talked about 3 or 4 decades ago. What do you look for in lead AVL? Or you're going to look for either a flipped T wave, or perhaps more commonly, you'll see ST segment sagging, which can also give you the appearance of a flipped T wave. So either way, ST depression and or T-wave inversion, or simply ST segment sagging like I've drawn up there. Get a repeat 12-lead ECG. How difficult is that? And you just might pick up the impending inferior wall STEMI and save a life. Simple take-home points. My thanks to all 4 folks that sent it.
Okay, so again, here's just the same thing, okay? So this one is a little more developed. You can see ST depression, inverted T wave in AVL, and again, the T waves here started to flatten out. The size of the QRS relative to the T wave, again, is problematic. So when you just look at this, if you're just looking for ST elevation, I think you're going to miss something like this. And I think that this would probably be sent to the cath lab, but it doesn't really have 2 or more contiguous leads of ST elevation. But I think anybody who's just watched that little video of Dr. Matu is like, well, duh, of course it's an inferior STEMI, okay? So questions about this? We're going to keep talking about it a little bit, but let me stop here. Any questions? Okay. Okay, I'm going to give you, this is sort of more the same. I like this one because it was a pre-hospital. So, darn, at one point I had this copied off, but I must have forgotten to bring it in. So, but you can see it from here. So, 87-year-old male with 2 days of chest pain. On the 3rd day, the pain worsens and he calls 911. So check out the time here, okay? So, so it's 2:55, and there's not much here, and certainly the computer, the printout on the computer is not seeing anything else. But what do you notice after, if you can see it, again, it's more of the same, so you should be able to guess what it is, even if you can't quite see it. What does AVL look like? What's concerning there? A little bit down, and what else? Tiny bit of what he called sagging, and what else is there? What was the other thing to look for in AVL? Excuse me?
Flip T.
Yeah, it's a flip T. It's that exact pattern that he drew out. And again, it's really subtle, so you have to look for it. So here's a little bit of ST depression, and there's the T wave, okay? So certainly no cath lab criteria, that's for sure. So there's our time. The symptoms got worse, and so whether it was, so now we're, it looks like it was a fairly long transport, so we're about 17 to 18 minutes on. But what is really significant, anytime you do repeat 12 leads, it's not just the specific changes, it's changes. And so if we go back, look at AVL here, and then 15, 20 minutes later, you can see it's changed. And that in and of itself is really significant, even if we don't quite have, we still don't have 2 or more contiguous leads. And in fact, the computer is just sort of not committing itself to anything. Okay, but now you can see the change. Look how much AVL has changed, right? And now we're starting to see some changes in the inferior leads as well. So that, let's go back for a minute. That's about a minute and a half change. So that's a big change in a minute and a half. And just those changes, when we talk about the mimics, I'm going to say 2 things. One is none of the mimics have reciprocal changes, and none of the mimics are dynamic in the way a STEMI is. And so that's one of the huge values if you have time to do serial 12 leads. If you start seeing changes on your 12 lead, that in and of itself is significant, okay? So we can see that, again, the computer's still not very impressed. So now we're going to go for another 3 minutes, and now it's there, okay? And at this point, the computer wakes up and says, oh yeah, I see it now, okay? But if that initial 12 lead, if you just looked at it and said, well, there's nothing bad here, and now what are we at? We're at 18 minutes. So 18 minutes after 3. So if that initial one, if you had simply looked at it and said, nothing here, and just driven into the hospital, they would have picked it up. but how much better for you to pick it up and let them know what's happening. Okay. Okay, so take-home lesson, and what do you do with a symptomatic patient who has concerning ECG findings? Okay, continuous, that's right. And again, for us, it's so easy. You just keep pressing the button. It's easier for us than in the emergency department because they have to sort of send a tech in and set it up again, and all we have to do is sit there and push the button. And so here we have it at 21 minutes after, and you can see how dramatic it's become in a pretty short amount of time. Okay? So, that's it for our re-examination of reciprocal changes. This part is going to be pretty short. Not much new here. I think that's all old. Typically, we see, yeah, this is one where nothing subtle about this one. Possible posterior, we can see it here. Typically, a posterior STEMI shows up with an inferior STEMI. And so, as we talked about before, for that reason, my advice is you don't need to take the time to move the leads around to the back. It only slows you down. You've already got cath lab criteria. What difference does it make in terms of getting that additional posterior involvement? They'll get that in the cath lab. But here is an example. So first of all, can we, Kyle, does this patient appear to have ACS symptoms? And and history that supports it, right? Okay. So, just to help you out here. So Anne, can you see that well enough? Is that two or more contiguous leads, ST elevation?
Yes, I think I can see.
Where?
In India. The elevation.
I'm going to say maybe. I actually don't agree with you. The J point here,
But the next beat.
yeah, that one. I mean, it certainly is, particularly considering that we're sitting here in 12-week class where we've drilled in inferior STEMIs. I don't think that's cath lab criteria. There's maybe a millimeter here, maybe not here. We have, straightened out T waves, and of course we're all looking at AVL, a little bit of, but not really cath lab criteria here. But what do we see?
There's depression and or
Correct, okay. So this is, so no STEMI criteria, although I think you're onto it that it's coming, but ST depression in V3, V4, little tight, sort of V2, large R's, upright T's in V2 and V3. So what does that tell us? Yeah, so a possible posterior. Now, this might be a time where you might want to take the time to move them around to the back. Of course, based on what Ann pointed out, it also might be in 5 minutes you're going to have your inferior STEMI anyway, but you might consider it. So I guess the point here, so here's where they did do it. So is there a posterior, V7, V8, and V9? I'll help you out here. Yes, it's confirmed. So a lot of times what you'll see with the posterior and then move them around is really small amounts of ST elevation. So this was the posterior. And then also, now we're beginning to see the inferior develop a little further. Okay, so this is really the only additional thing today that I've said it before, but I really want to emphasize it, is that typically posteriors come with an inferior, but don't, the most missed STEMIs are isolated posteriors. And that makes sense, right? Because we think, it's only there with an inferior. And I'm not talking about paramedics, I'm just talking in general, that the isolated posteriors are missed. So 3 to 11% of posterior MIs, there's no other area involved, so isolated, okay? So, okay, we're going to finish up the lecture today with non-ST elevation ACS, or NSTEMIs is one version of that. And I'm going to put kind of a qualification on this part of the lecture. By far, I find this section the hardest thing to teach all year. It's not the hardest thing to learn, you'll be happy to hear, but it's the hardest thing to teach. And the reason is because it's an area that's changing really fast. So I can't tell you how many times I've updated this section, including, a couple of weeks ago. It just keeps changing, and I don't think it's going to stop. Now, why would something like that, why do you think our knowledge of non-ST elevation acute coronary syndrome, why is the conclusions we come to, the treatment, sort of our knowledge of it, why is that expanding? Why is it changing? What do you think? What's different now, say, than 10 years ago? What do we have in our, say it again?
Technology.
And specifically what technology?
The 12 lead, they're getting better and smaller and easier to use.
Yeah, I don't think it's the 12-lead technology, although, it's a good answer. But what technology is changing? Not pre-hospital stuff, hospital stuff. What's changing? Say it again?
Cath lab ability, I have no idea. I'm just throwing out answers.
Ultrasounds?
Yeah, so I'm just going to put that in the category of imaging. Imaging is way better, so we really understand better what's happening within the heart itself. What else has gotten way better when it comes to assessing STEMIs and acute coronary syndrome? What has really gotten significantly better?
Blood draw?
Say it again?
Troponin?
Yes. So what they're now able to do is our ability to assess the troponins and other proteins in the blood is way higher than what it used to be, which means we're able to pick up more and more subtle amounts of damage. And so our understanding of what's happening in here is changing. And just an example of what I was trying to kind of cobble together for a lecture was, there was an article, do all of you know about UpToDate? Any of you use that? It's a really terrific subscription service that you have access to via your OHSU ID. And it's written for clinicians, so mostly doctors. It's exactly what it says it is. It's up to date, so it's articles that to me are kind of the perfect level of information. I think all of you would have no trouble understanding them. They give you great information, and it's peer reviewed sort of frequently. I don't know, I think it's probably every year. And so it's exactly what it sounds like. It's up to date. And, and it's not just emergency, it's just medical stuff in general. They've got really good stuff on drugs. So it's just an excellent resource. So I was reading, in preparation for this lecture, this is just an example of how things are changing. I was reading an article about unstable angina versus NSTEMIs. And as you're going to see in a few minutes, our distinction between unstable angina and NSTEMIs has to do with the ability of whether there are troponins in the blood. If there are, it's considered an NSTEMI. If there's not, it's unstable angina. And again, I'm going to repeat that in detail in a few minutes. Well, the top part of the article essentially said, this is a distinction that's fading because with our better ability to, assess troponins, we're beginning to realize that unstable angina also has troponins. So it's a distinction that's starting to merge together. That was the top part of the article. The bottom part of the article was, this is the difference between unstable angina and NSTEMIs, is the ability, is the presence or absence of troponin. So in other words, the top part of the article is the new, what's coming. The bottom part of the article is what we have now. So here's my qualification about this part of the lecture, is everything that is in there, I used references that were no more than 5 years old. None of it came from books, because that's always old. Sort of the best I could do. My guess is what I'm telling you is going to be quickly out of date. Hopefully it'll be good for a few years. And my goal is to give you information that you can use. So, and not get too bogged down into, maybe we don't agree with this. Okay. So, with all that, let's jump into it. When you have a patient whose presentation is consistent with acute coronary syndrome, that's important, and their 12 lead shows ST depression, is that depression always reciprocal changes? Because that's the only thing that we've talked about so far is reciprocal changes, or, for a posterior STEMI, also reciprocal changes. And in order to answer this question, we're going to review the different categories of acute coronary syndrome. So we have acute coronary syndrome, and we can subdivide acute coronary syndrome, once we do a 12 lead, into those that show ST elevation and those that show no ST elevation. With ST elevation and 2 or more contiguous leads, we know where that ends. So that's one big, relatively simple category of ACS, are the STEMIs. Okay, and we've done that. But what happens when we have somebody who seems the clinical presentation is consistent with ACS, but there is no ST elevation in the 12 lead? So we call that non-ST elevation acute coronary syndrome, or NSTE-ACS. And we can further subdivide it, at least for another few years until they change the subdivisions, into NSTEMI, which is non-ST elevation MI, and unstable angina. So our topic right now is non-ST elevation ACS. It refers to any acute coronary syndrome which does not show ST segment elevation. And again, just to repeat, the 2 main categories that we have now are unstable angina and STEMIs, non-ST elevation MI. So what do these mean? So we're going to start by talking about, well, before we get to unstable angina, let's define what stable angina is, because that will make it easier to discuss unstable angina. First of all, Anne, what is angina?
It's where coronary arteries have occlusion, or they have buildup.
So I'm going to, what you're saying is all good, but you're not answering the question. So, because what you're doing is giving me, excuse me?
How it presents.
Okay, I'll go with that. So the old definition of angina, when a patient says they have angina, the old definition is chest pain or discomfort. I mean, that's what angina means. If you look up angina, it's chest pain. But for our purposes, we know that's out of date. Why? Why is that out of date to say merely chest pain?
That's not always pain that the patient feels.
Right. We know the shortness of breath, the nausea, all that stuff. In this context, what we're going to use for angina is any possible acute coronary syndrome symptoms, okay? So here is the definition of stable angina. Another way to say this is stable ischemic heart disease, okay? When chest pain or other cardiac symptoms, so when ACS symptoms occur in a predictable pattern, okay? So if you have Mr. Jones who had an acute had an MI 5 years ago, and every day he walks out a long driveway, he walks out to his driveway to get his mail, and he walks back. If every day he walks out and that causes some chest pain every single time, and it causes 2 out of 10 chest pain every single time and maybe a little shortness of breath. But when he gets back, he sits down and maybe he takes a spray of nitro or something, but it's the same thing every day. And the pain or the symptoms resolve, the shortness of breath, the pain, whatever it is, resolve, we consider that stable angina, okay? Angina is no longer considered stable when the ischemic symptoms occur while at rest for 20 minutes. So he comes home and usually they resolve in 10 minutes, but it keeps going for about half hour. Probably his doctor would have told him at that point, if that happens, call me up, call 911, whichever direction it goes, because it's too long. It's out of the norm. It's unusual. All new onset, never experienced before, ACS symptoms are considered unstable angina, or considered unstable. And then there's sort of a very particular term, which I don't care if you memorize crescendo pattern. I don't think that's so significant. But again, this is sort of similar to this. If it's worse than usual, longer than usual, it's considered unstable. Okay? So, now that we know what we mean by unstable, what's the difference between unstable angina versus NSTEMI? Now remember, both of these, there's no ST elevation, okay? Mr. Jones comes back from walking out to his mailbox and he sits down and the pain doesn't resolve, so he calls you and you come and of course you do a 12 lead and there's no ST elevation. But he still has these symptoms, okay? So in that case, the chances are good, if this is caused by cardiac reasons, that it's going to be unstable angina or NSTEMI. NSTEMI is distinguished from unstable angina by the presence of elevated cardiac biomarkers. So COA, is that something that you can figure out? No, okay? So what this means is that just ECG findings are not enough to tell these two conditions apart. So your ability to sort of even predict NSTEMI versus unstable angina in the field don't exist, okay? So, the most you can say is, well, this is, this is non-ST elevation ACS. If that's too big a mouthful for you, very well maybe, you can also say possible NSTEMI. But if you're being accurate, don't say I'm coming in with a patient who has an NSTEMI, if you want to be precise, because you can't tell for sure, okay?
So,
Yep.
you don't issue, obviously there's no STEMI alert because it's not STEMI, but you're still going to a place cath lab capable.
Yeah, there
most
are,
likely.
let's go through the ECG findings. You're asking the most important question, well, what do we do? But let's go through the findings and we will definitely spend some time talking about that. Okay. Okay, did that. Okay, so again, just to sort of drive this point home, we can identify STEMIs. If we're doing our job, we can identify STEMIs. We might be wrong or right, but we know how to do it. We can suspect the presence of non-ST elevation ACS, which is a combination of clinical presentation and ECG findings that we haven't gone through yet, okay, which we're going to do in a few minutes. But we can suspect the presence of that. But what we can't do in the field is we can't tell the difference between NSTEMI and unstable angina. Now, generally the presence of acute coronary syndrome is determined by 3 factors: history and clinical presentation, ECG findings, and cardiac biomarkers, unless it's a STEMI, in which case they get to the cath lab first. But for our purposes, we know about clinical presentation. Let's look at the ECG findings. STEMI, we know all about that, okay? We're not going to do that today. So what are the ECG findings that make us suspect non-ST elevation ACS? So one of them is T-wave inversions, which may or may not be useful. If you walk on scene and you see T-wave inversions in a bunch of leads, don't be tempted to say, oh my God, NSTEMI, let's run off and take them in code 3. On the other hand, if you do a serial 12 lead and a bunch of leads that did not have T-wave inversion before now do, that's a pretty good sign that that's caused by ischemia, meaning non-ST elevation ACS. So must be dynamic. Now it says either change from previous ECG, and I don't know any time when when the patient hands you and said this is the ECG that they did in the ED yesterday, and you can compare. We don't have that luxury the way the ED does frequently. Okay. So again, if you see the T-wave inversions, if you see the change, then that's significant. But ST depression, for that reason, is more useful for us in terms of trying to identify non-ST elevation ACS. Now, before we go further and look at some 12 leads that have the significant amount of ST depression that suggest non-ST elevation ACS, let me really emphasize this point, that T-wave changes in ST depression are not solely associated with ischemia. There are other conditions that can cause them. So, for example, an easy one would be electrolyte imbalance, can cause these, okay? So what that means is that all the stuff we're going to go through right now is very significant if you have a patient who has history and clinical presentation of acute coronary syndrome. But if you have a patient that, maybe it's a 60-year-old person who fell off a ladder and you're very smartly say, after you're transporting them and doing all the things you need to do, and you say, oh yeah, there's that thing about people over 60 falling off a ladder or cardiac cases until proven otherwise, and so for that reason, you do a 12 lead. But they don't present in any other way other than they fell off the ladder. They have no ACS symptoms. At that point, you're thinking, well, if I see ST depression, it's a little iffy. Does that make sense? That came out a little garbled. But I guess I want to say clinical presentation is super important here. So let's look at some examples. Okay, Grace, does this fit the presentation and history of a patient with ACS?
Yes.
Yes, okay. So here's the 12 lead. Okay. So, Koa, why don't you go through all the leads and tell me if you see, just go through, you can skip AVR, just tell me if you see ST elevation or depression and where you see.
I see ST depression in 2, 3, a little bit in AVF, V3, V4, V5, and V6.
Okay. So definitely widespread, what we taught, the term we're going to use for this is widespread diffuse ST depression. What do I mean by diffuse? What does that mean?
Everywhere.
Say it again, please.
Across the board.
Yeah, across the board. So the opposite in this case of diffuse is localized. So if you see ST depression in 2, 3 AVF, that's localized, it's in an area. But if you see it like this, it's diffuse. So what we're seeing here is ST depression across the board. When there is no ST elevation, look for diffuse ST depression as a sign of non-ST elevation ACS. The more widespread, the more leads that we have, the more serious it is likely to be. So in this case, there may be the tiniest bit in one, probably not even maybe just a tiny bit, but we definitely have it in 1, 2, 3, 4, 5, 6. We have it in 7. We have ST depression in 7 leads. So that's a lot of leads. And maybe we have, again, just the tiniest bit in V2 and 1. Yeah, maybe. This patient was taken in. This is a 12 lead. The patient has the history and clinical presentation of somebody with acute coronary syndrome. They have a 12 lead that suggests non-ST elevation ACS. So they were transported into the hospital, tested for troponins. Yes, they were there. This patient had an NSTEMI. Okay? So let's go through another couple examples, and then we'll circle back and talk about what you do. Okay? Okay, so Anne, does this patient have the presentation and history of a patient with acute coronary symptoms? Yes. Okay. Elderly female in particular, no chest pain, but we don't, I hope all of you say, of course I do, 12 lead. Okay, so here again is the 12 lead. Let's see, do I drop? Okay. So Kyle, do you want to go through, please, and tell us where you see ST depression? Oh, the red line's sunk down. We're just going to take them away. I think you'll have a better time. They're not positioned right.
See 1, 2, 3,
Mm-hmm.
and AVF. Kind of hard to see an AVL. Question B2, B3, B4, B5, maybe a little B6.
Yeah.
I'd say B6. So
Yeah.
Everywhere.
Yeah. So again, is this widespread diffuse ST depression? Yes, it is, of course. So this is non-ST elevation. Again, history, presentation, check. 12 lead, ST depression all over the place. Again, this was another NSTEMI when they were taken in. Okay. Koa, does this patient fit the presentation history of a patient with ACS?
Yes.
Yeah, absolutely. And Grace, what about here? Can you see here ST elevation, ST depression?
You have depression in 2, 3. Wait, JK. Wait, no. Right.
Yeah, I agree with that.
AVF, B1, B2, B3, B4, B5, B6.
Okay. So this particular patient did not have positive troponin, so this was unstable angina and not an NSTEMI. That being said, just out of curiosity, looking, I'm leading you down this path of, telling you what to think here, but what else is suggested possibly by this 12 lead? What do you think?
Posterior.
Yeah, this actually could be. I mean, there's a whole bunch of it. This is, again, it's not, I'm just putting this forth not because I have the answer. This patient did not have a posterior, but you would not be silly to think, I know I see all this ST elevation, but look how dramatic it is here. Maybe I'll just do a check around to the posterior. So it's, again, as always, I'm sort of cherry picking a little to make a point and giving you ones where it's more obvious rather than less obvious. And then remember, in the field, all we can say is suspected NSTEMI, okay? So I think that's a good way to say it instead of possible non-ST elevation ACS. I think everybody knows what an NSTEMI is. But if you want to be precise, don't say NSTEMI, just say possible or suspected. If they say, why do you think that? And you would say, because they have the history and presentation of acute coronary syndrome, and they have ST depression in 2, 3, AVF, V3 through V6, something like that. Okay. Okay, Chris. How does the suspicion of non-ST elevation ACS change your treatment, if at all? What do you think?
Can't call STEMI alert.
No? Correct.
Obviously, you still wanna go to a cath lab.
Good.
Or a cath lab capable facility.
Mm-hmm.
Just in case the patient doesn't have an STEMI, like they confirm. it.
Right.
Move quick.
Move quick. Good. Good. Always a good answer.
That's all I got.
See if I have anything else. Okay. Anybody want to add? I have a few other things, but
Oh, and the continuous probably is.
okay. Check. Got that one. Okay. So, so this may be a high-risk patient. So really everything that Chris said, move quickly, short seating time, transport to a cardiac hospital, transmit or describe the 12 lead and do serial 12 leads. Code 3 probably depends a bit on the clinical presentation, but I think the most important thing you can do is this may be a high-risk patient and you really want to be able to persuade the hospital coming in, I have this patient, they're not a STEMI, but I think this could be serious, could be a possible NSTEMI, and they say, medic 16, 17, why do you think that? You know, and you should be able to explain why, okay? So that to me is the best thing you can do in these situations. Questions? Okay. A special case, okay, so yes, ACS, we know that. Natalie, what are the significant ECG findings? See, did I drop the, oh, here, let me help you out. Oh, let me really help you out.
Yes.
Okay, so we've got widespread ST depression. There's another significant ECG finding that I've told you, don't bother looking at that lead. Which one is it?
AVR.
And what's an AVR? Yeah. So, ST elevation in AVR, okay? This is another thing that has changed in the last, I'm going to say 10 years, because I'm not entirely sure how many years, but 10 years is kind of a nice amount, is that more and more AVR, you know, it used to be the totally useless lead. And more it's like, okay, there are some things we can do with it, okay? In this particular case, this pattern is indicative of a possible left main coronary artery occlusion. It could also be a proximal left anterior descending occlusion, also very bad, or triple vessel disease, also very bad. So let's look, before we talk about this a little more, where exactly is the left main coronary artery? Well, it's pretty short because it bifurcates into the LAD and the left circumflex. So the occlusion would be here, so you can see why this would be significantly bad. Now notice when we say occlusion, that doesn't mean complete obstruction. If it was that, the 12 lead would be significantly different, okay? Let's go back and look at it. So here we have the, again, it's significant, like, you know, 6 or greater leads with ST depression plus elevation in AVR. So how do we describe this? I think the best way to describe it would be to say non-ST elevation ACS or suspected NSTEMI with possible left main coronary artery occlusion, if you want to add that in. Okay. Now, yes.
The R wave in V1 seems to be a lot larger than normal. Is that indicative of anything?
I'm not sure. I don't know if it is. It's a good observation. By itself, I don't know if it's by itself, if it's something. So I think I'll just leave it at that, because if I look at it, you know, the R wave progression, except for that, is not necessarily that bad.
Mm-hmm.
So I don't know if it means anything or not by itself. For this year, for now, if this was a 12 lead on the test, I would like you, if I'm asking you, what are you seeing? I would like you to answer something like suspected NSTEMI with suspected, and you can abbreviate it if you want, LMCAO, or you can spell it out. The reason I'm clearly hedging my bets a little bit is this is another thing where when I was updating this lecture, there were a couple of studies that popped up and said, that left main coronary artery occlusion thing, we're not so sure anymore if that's what's happening here. So this may be something that's changing, but for now, we're gonna leave it in, okay? And next year, if somebody says, oh no, that's old news, I'm sort of like covering myself either way it goes. But for now, let's leave it in. Okay, so here's another example. So widespread ST depression in 1, 2, 3, AVF, and V3 through V6, plus significant elevation in AVR. And another example. You can see significant elevation there. Okay? So, final note on this particular pattern. And again, widespread ST depression with ST elevation AVR is sometimes thought of as a STEMI equivalent. So what do I mean by that? I don't think, as far as I can tell, the American cardiologists have not made it formal that this is a STEMI equivalent, meaning that if it was written into your, you would say a STEMI alert. But in Europe, for some years, they have thought of this as a STEMI equivalent, that this person would be rushed off to the cath lab. So I can't say that in this country we're doing that, but enough to take it seriously, okay? And again, only in clinical presentations consistent with ACS. So, okay. Okay, so let's kind of sum everything up. With symptomatic patients, pay attention to ST depression. First, just check to see if it's localized. Again, what you're really doing is looking for reciprocal changes. Localized here means localized in one area or another, or in several areas, okay? If the ST depression is in those early V leads, consider a posterior MI. If the ST depression is widespread without any ST elevation, consider possible evidence for non-ST elevation ACS, or if you want to call that possible NSTEMI, I'm okay with that. Okay? And then remember the pattern of widespread ST depression with elevation in AVR means that in addition to the possible NSTEMI, it could be left main coronary artery occlusion. Final important footnote, okay? You're called to a patient and they appear to be an SVT. And you decide before you treat them, if you are going to treat them, that you'll do a 12 lead. And this is what your 12 lead looks like. Okay? If you go through, you will see that there is ST elevation, significant ST elevation in multiple leads, plus ST elevation in AVR. Okay? SVT does this, okay? This is a common finding with SVT. So the best way to handle this is give them some adenosine or cardiovert them or whatever you're going to do, and then do a 12 lead. And if all that ST depression and ST elevation in AVR is there, then it's something significant. But other than that, until proven otherwise, this is almost certainly there because of the SVT. So if you look at multiple 12 leads with SVT, you will see it's a really common pattern. So don't be fooled on that one. Okay? Now, before we stop this lecture, we're going to do a bit of practice. But before we stop, and we'll stop the lecture and then do a break, and then we'll do the practice. We're going to circle back. We've talked about the difference between NSTEMI and unstable angina. We're actually going to talk about, well, we've talked about what an NSTEMI looks like on an ECG, but what actually is the difference within the heart, STEMI versus NSTEMI, okay? And again, this is one of those areas that's changing, okay? What you read now is different, say, than what you read 10 years ago. And it has to do, with our ability to use imaging in a more sophisticated manner, okay? So, and this is not really the topic of this class. I'm certainly, I'm sort of adding this in because I expected questions, and even if you haven't thought of them yet, I know I've actually had questions in this class before about that, and I think it's an important part. So, non-ST elevation is an evolving area of medicine, as I've already said. There's a lot of outdated info out there. So if you're doing your own research on this, be really careful about this. I wouldn't use a book on the, books are great, but as we all know, even really great books, even textbooks that have just come out are, by nature, at least 5 years behind the time. I would be careful about using old references, and like I said, my somewhat arbitrary decision when I put this lecture together was say I won't use anything that's more than 5 years old. So watch out if you're doing your own. So what is our definition of a STEMI? Okay, and this was 2020. Defining and managing patients with non-ST elevation myocardial infarction. So I thought, okay, that's good enough. I'll use this definition. STEMI is usually characterized by severe and/or total coronary flow obstruction with transmural ischemia. What's transmural mean? What's transmural mean? Say it again?
Across something.
Yes, so it's the entire depth of the myocardium, okay? The ischemia, not necessarily the infarction, but typically, usually, with a STEMI, we think of it as a transmural event, meaning it's affecting the whole myocardium, okay? Which predisposes to myocardium necrosis and pump dysfunction. Okay, that's pretty straightforward. So if that's a STEMI, what's an NSTEMI? From the same article, they defined NSTEMI as usually, again, seeing they're hedging their bets a little in both definitions, results from a flow-limiting coronary stenosis. What does stenosis mean? Narrowing, okay? So when you have a stenosis, it's narrowing, okay? It can be caused by a variety of things. Could be caused by a clot, okay? Could be caused by a spasm. From a flow-limiting coronary stenosis with resultant downstream myocardial ischemia, okay? Damage is typically, but not always, less than a STEMI. So in other words, if you have a choice, if somebody says to you, well, you got to have a STEMI or an NSTEMI, choose the NSTEMI because you're likely, it's likely to be less damage. But the STEMI is really characterized by a severe or almost complete obstruction, whereas an NSTEMI, remember the actual difference is what you see on the ECG. Is there non-ST elevation? Is there no ST elevation, or is there ST elevation? So if you have a coronary event, it's an NSTEMI, they're still saying, well, a flow-limiting coronary stenosis, but it doesn't have to be as bad. Now, it used to be thought, so like I said, this is, these things change. It used to be thought that NSTEMIs are not caused by complete blockages. That used to be a definition, is that, STEMI, it's like a total blockage, and an NSTEMI is a slight blockage. That's not the case. Total arterial occlusion is present nowadays, we know, in approximately 25% of patients with STEMIs. However, it may be that they're in a less serious artery, a smaller artery, but it's still a complete obstruction. So if somebody says to you the difference between a STEMI and an end-STEMI is one's a complete blockage and the other one's not, that's an old definition. They're not wrong, they're just a little bit out of date, meaning they're wrong, but they're not bad people. Okay. So it also used to be thought that STEMIs always resulted in complete muscle transmural ischemia, and end STEMIs resulted in what's called subendocardial ischemia, okay, meaning close to the endocardium here, okay. And again, that frequently is the case, but this idea is also evolving, okay, and I'm just threw in, this was the hardest thing to pin down, so I finally got a quote and threw it in. Against the old perception that transmural infarction is found only in patients with STEMIs, while patients with end STEMIs had only subendocardial infarction, recent studies using, I don't know what this is, showed that a percentage of patients with end STEMIs had transmural infarctions. So in other words, the differences that we thought were there are just not there. So it can be that an end STEMI is a complete blockage and that it results in transmural infarction, even though no ST elevation. But generally speaking, it is still the case that a STEMI will cause worse damage than an end STEMI. However, patients after STEMI have a higher in-hospital mortality rate and worse short-term outcome, but mysteriously, end STEMIs have a worse long-term prognosis. And I couldn't track that one down, and at some point I thought, a few years somebody will know the answer, so I'm not going to worry about it now. So what about, how is an end STEMI treated? Well, first of all, how is a STEMI treated? So, Cole, how is a STEMI treated?
Cath lab and either SIT or...
Yeah, let's just say cath lab. We're in Portland, cath lab. Yeah, okay. So, but what about that patient you bring as an end STEMI? How are they treated, okay? Because that's really at the heart, when you ask your question, Chris, that's really the basis. What's the hospital going to do? Are they going to send them to the cath lab? So they don't feel like they have to act as quick, as far as I can understand. That would be, based on clinical presentation. So based on a variety of things that we're not going to talk about now, they estimate the risk. Okay, this is an end STEMI. We have the troponins, but how bad is it? So they estimate the risk, and then they have a choice of management strategy. They can have early invasive strategy, so that's PCI. So maybe they'll go to the cath lab, or they can have a more conservative strategy with medical therapy. Okay, so initiation of, for example, they can give them antithrombotics. That is one possibility for an end STEMI. So again, whereas a STEMI typically, we know what's going to happen, an end STEMI has a wide variety of treatments, or a variety of treatments, and a variety of timing. Okay? Okay, so we're going to take a break. Let's take a 10-minute break. Come back at 5 after, and 10:05, and then we're just going to do some practice, and then we'll be done. So we'll probably be out of here. Okay, so this is the handout, and we'll just, let's just do it together. So what you want to do is all of these have ST depression. Which leads do you see ST depression, and then select the most likely reason for ST depression. So, Anne, why don't you do number 1? And, take your time. I know you're jumping in there.
I see. Depression. A tiny bit in 2, 3, AVF, and then I see elevation in AL,
So the question, so that was great. The question you want to answer is the reason for the ST depression.
Okay, I think in this case, the reason is reciprocal changes
Okay?
with, lateral. Hold on.
Okay.
There might be a possible posterior,
Mm,
sorry, no. There's a septal.
Yeah, you're correct about that. I'm just going to jump in here. You're correct that there is, and certainly that if you were given this 12 lead, that would be a very important finding. Specifically, what I'm asking here is there ST depression? Yes, there is. You accurately said in 2-3 AVF, and then the question you have to answer is, well, why is that to the best of your knowledge, looking at this 12 lead, why is that ST depression there? And you accurately said reciprocal changes, specifically to the high lateral. So you're correct about the septal anterior STEMI there, but
Would you say
Yes.
though,
Go ahead.
I'm seeing some elevation in one, but it's pretty minimal. Would you
Oh.
call that?
oh, I see
For
what you're
my-
saying. You're wondering if
For the one in AVL, I mean, definitely it's AVL, but for the.
yeah. So in this particular case, I would have no trouble calling this a high lateral STEMI. No trouble at all.
And because
Now,
the
again-
the T-wave's flat.
Everything about, there's definite ST elevation in AVL, maybe half a box in one, and I know we're supposed to have contiguous, 1 millimeter, but combined with this very dramatic ST depression, I would have no trouble, I said, no, I would have no trouble calling that. There's also happens to be a septal anterior STEMI, so you're kind of off the hook in terms of a STEMI alert, but I think the inferior is definitely there. Okay, Kyle, number 2, please.
I see depression in 1, 2, 3 is really wonky and kind of hard to see. It does look like you kind of have a bit of a flat segment there, but because the isoelectric line's so weird, I don't know if I can call it depression, but it definitely has a flat segment.
Yeah, it is hard. I think I still would call it because you have to say, well, the TP segment is sort of here and here, and it does seem, even though it's low quality, that as you correctly say, it's flat and it seems to be a bit lower than the
And the
isoelectric line.
same thing, it's kind of got kind of hard to call it depression, but it's definitely got a flat ST segment in AVL.
Correct, I agree with that.
I can't remember if it said depression in AVF,
Mm-hmm.
depression in V4, 5, and 6. There's kind of depression in V3, but it's upsloping. I'm not as concerned about that. And there's elevation in AVR.
Yes. So what are you going to call this?
Possible and STEMI.
Yeah, and what does the elevation in AVR tell you?
It's
Possible
left main
and-
coronary artery or
Yeah.
proximal occlusion.
Yeah.
Large intestinal.
Yeah, so suspected end STEMI with possible left main coronary artery occlusion. I put that in, but I think I started the handout saying they all match ACS, if clinical presentation points to. So questions about this? Okay, Cohen, you're next, number 3. Oh, you lucked out.
Depression in the high lateral, and I think that's due to reciprocal changes from the inferior.
Okay,
There's ST depression in the septal anterior, and that's possibly due to a posterior STEMI.
perfect. Okay. Okay, Grace, next one, please.
Number 5.
4.
Okay. There is SD depression, or.
Oh, excuse me.
AVF, B3 through V6, that's widespread depression. I'm saying a suspected and STEMI.
Correct. Okay. Questions? Okay, Natalie, number 5, please.
First of all, I'm seeing depression in V2, V3, V4, maybe a little bit in V1 as well,
Mm-hmm.
and a little bit in V5. So I'm suspecting maybe a posterior MRI. I would definitely check for that. And I do see elevation in AVR, so it could be the what's it called? One occlusion, left vein
Okay.
arterial occlusion potentially.
And I'm sorry, I missed what you said in the limb leads. What do you see there?
Saying V2 through V.
No, limb leads.
Oh, limits 2,
Uh-huh.
depression,
Okay.
AVF depression, maybe a little depression in 3.
Okay.
Especially they're grouped together.
Okay, yeah.
I don't really see elevation.
Okay, so I said suspected end STEMI. Yeah, it wouldn't hurt to check for possible posterior. It's also very widespread. There aren't R waves in V1 and V2, but yeah, you could always check. The ST elevation, yeah, there is a bit of ST elevation, so you're fine adding the left main. I don't have it here, but I think you're okay adding it. Yes, Kyle?
Not that the ST depression in V3 and V4 isn't completely obvious, but would that still be considered a Wellens sign too, with the T's upside down?
No, because Wellens is up first, down second.
Okay.
So Wellens, when it's the biphasic form, is that you're talking about the biphasic form, I assume?
I was just talking about the inverted T waves.
No, you really, Wellens, you have to, so what you're saying is it possible if there was no ST depression, it might be Wellens?
Okay. Yeah.
Is that kind of what you're saying?
Yeah.
I guess it's possible, but I wouldn't put it in because you just need to be able to see it.
Okay.
So, yeah. Okay, Chris, you next, please.
6, right?
Mm-hmm.
Let's see. Looks like a tiny bit of ST depression in 2. And V1, yeah, V1, V2, and V3 as well.
Mm-hmm.
And I think that's it.
Okay. So what's your best guess about why the ST depression is where it is?
Possible posterior?
Absolutely, an isolated posterior, definitely. Okay, it's got the whole shebang, the whole circus pony, right? It's got the fairly large.
I forgot about,
Yeah, the upright, but really the ST depression is the most important part. And there really, there may be a little bit in 2. I don't quite see it, but I sort of see what you're talking about. But there is no other, so this is it. Now notice that all of these things with ST depression, with the exception of reciprocal changes, we have to put possible in front. We don't quite know. We need to do more exploration, not all of which we can do. So.
So like on the final, do we need to include possible to get full points?
No,
You know.
but include it. Yeah, include it. So since include it. Okay. Anne, you're next, please.
Okay, there's not too much depression going on here, maybe a little bit in 3 and APL.
Mm-hmm.
And I think that's just reciprocal change.
Okay, I agree with that. And what's it reciprocal to?
For there's elevation in V2, V3, V4.
There certainly is elevation in septal anterior, no question. I mean, you're off to the races with this one, there's no question. But let's go back and look
So also,
yeah.
one in AVL, it's hard to see, but.
It is hard to see.
The T waves are flattening.
Yep.
and The relation
Yep.
applies to the flora.
So most likely here is the possible reciprocal changes to evolving lateral STEMI is your best guess here, which is what you said. I totally agree. It's not, if this is all we had, the limb leads, and we didn't have the stuff over here, you might want to not do a full STEMI alert, but, do our favorite repeat ECGs and, tell them what you see. So. And also, how many times have we said this? If we've got a very dramatic STEMI on one side and then something that appears to be coming on the other. So just the fact that there's a STEMI here makes the evolving STEMI even more possible there, if that makes sense. So, okay. Kyle, number 8, please.
The only that we saw depression in was the ABL, but there is elevation in Q3 ABF and B5 and B6, so it's most likely a reciprocal change.
Yep. Okay, and Cohen, number 9, please.
For number 9, there's slight depression in 1 ABL, and I think that's reciprocal changes to the elevation in the inferior leads.
Nice. Okay. And then Grace, number 10, please.
I saw depression in 2-3 ABF, which is probably reciprocal to lateral.
Nice. And then Natalie, number 11.
I see a little bit of depression in 2-3 ABF as well as B1, B2, B3, B4. So I'm thinking maybe an STEMI. I don't see any elevation anywhere.
Okay.
It could also be a posterior.
Yeah, this is a hard one. This is actually the one we were looking at before. So there's 2 ways to interpret this, and I don't think either one is, again, these are all possibilities. So I don't think, if this was on the test, I think there's 2 options here. One is that we do have suspected end STEMI, because there's an awful lot of ST depression. But I don't know, that lateral, unfortunately, I think what I would do is just do another one and keep doing them, but you're absolutely right, possible posterior. So this one is pretty equivocal, We're doing this all as we're racing to the hospital, no matter what, because this one certainly doesn't look good. And then our last one, Chris, number 12.
All of the ST depression everywhere except for AVR.
Okay.
And there's ST elevation and the SVT.
Good. Okay, I thought I would trick you, but I didn't. So remember, this is, I guess we have another one coming. Yeah, so watch out for this one. You don't want to be the newbie on scene who's like yelling about left main coronary artery occlusions and the fire captain is looking at you like you're an idiot. So, okay, what about this one? Anne?
So widespread depression and there's elevation in ABR, so maybe that is STEMI.
Okay. And what about the elevation AVR?
It's
Yes. Okay, let me rephrase the question. What are the implications of the AVR that we can clearly see?
the left coronary artery.
Correct.
Occlusion loss.
Yeah, correct. Okay, so that is it for